Hello, and thank you for joining us. Today we're with Dr. Alice Gottlieb, who spoke at the South Beach Symposium 2021, Time to Think About Both Skin and Joint Disease, Optimizing the Diagnosis and Management of Psoriatic Arthritis. Dr. Gottlieb, can you tell us about screening tools that are currently available for psoriatic arthritis patients?
The only screening tool for psoriatic arthritis that is available for free is called the PEST. It consists of 5 questions related to psoriatic arthritis symptoms and signs. If a patient answers 3 or more of those in the positive, they are considered to possibly have psoriatic arthritis, and the healthcare provider needs to act upon that possibility.
Thank you, Doctor. Can you tell us what is your personal approach to diagnosing psoriatic arthritis patients?
I'm both a dermatologist and a rheumatologist, so my answer is not typical of what every dermatologist would do. Being a rheumatologist, I actually ask about symptoms of psoriatic arthritis, and I examine and look for signs of psoriatic arthritis.
Wonderful. And as you have said, you are a dermatologist and a rheumatologist. Do you have any words on what you feel the dermatologist's role is in the treatment of psoriatic arthritis, or any advice for dermatologists working with rheumatologists as part of a team approach?
I feel passionate about the key role of the dermatologist in preventing disability due to psoriatic arthritis. Psoriatic arthritis is common. In fact, it is the most common comorbidity of psoriasis. And in most cases, it's easy to diagnose. Left alone, psoriatic arthritis can be disabling. And it's unfortunate in that setting that psoriatic arthritis frequently goes underdiagnosed up to 41% of cases. And that's a shame because cutaneous disease precedes arthritis by an average of 10 to 12 years in 84% of patients. Therefore, the first doctor who is likely to diagnose psoriatic arthritis is not the rheumatologist, it's the dermatologist. And this matters because we have in the United States 4 TNF blockers and 2 IL-17 blockers that not only control signs and symptoms and improve quality of life, but actually inhibit radiographic progression. It may be that guselkumab, an IL-23 blocker, will eventually have this same label, but it is now currently approved for improving signs and symptoms and improving quality of life. Work is in progress to try to get an inhibition of radiographic progression indication for guselkumab. Therefore, dermatologists can prevent disability by initiating treatment early on. Also, I don't know how one decides how to treat psoriasis if one doesn't know first if the patient has psoriatic arthritis. That is the first question I ask them. Why? Because somebody can have very limited psoriasis that one would treat topically if one doesn't know that they have psoriatic arthritis. If they have psoriatic arthritis, that changes the treatment paradigm immediately. One goes to systemic treatment. And it's very important to note that the presence of psoriatic arthritis is independent of presenting psoriasis severity. Yes, it's true that if you have more severe skin disease, you are more likely to have psoriatic arthritis. However, 25% of patients who have mild skin psoriasis have psoriatic arthritis. So my policy and my teaching is ask every psoriasis patient at every visit about musculoskeletal symptoms.
Wonderful. Thank you so much for that, Dr. Gottlieb. That's all the time we have today, but thank you so much for answering our questions.
My pleasure.